I can't live up to it. I want to thank you all for coming and for having me. I think that's both very nice introductions. I was thinking all of those great programs you're putting on here in this school, and I wish I could attend them. I am also intimidated by the number of different constituencies here, with different interests, different knowledge bases. And I can only say to you all, I'll be speaking to the others whenever it is that I'm not speaking to what you want. And that's one reason after the 12 o'clock hour, we plan to have an additional question, discussion, disagreement period. You know, a public one, not a one-on-one. Because I can't speak to all the constituencies here and do what needs to be done and live even remotely up to the title that's been publicized. Which you can all read, so I'm not going to say it again. I have to thank all my grants that helped contribute to the material I'll be presenting. I particularly have to present the thank the hundreds and hundreds and hundreds of people who took part as research participants in various studies, thousands. And the folks, both colleagues and participants and others I have known who have died from HIV and Hep C. This is dedicated to that, obviously. And I thank all my many collaborators and co-authors and the like. I'm going to talk a lot about networks, risk networks, and social networks as distinct, conceptually distinct, though often the same people, but not entirely. And other aspects of social organization that affect the spread of HIV and how you can prevent the spread of HIV. I'll end by talking about how we're using that in my current project in Chicago among African American MSM, in Athens among drug injectors, and in in Odessa in Ukraine, primarily among drug injectors and their networks. But the networks cross boundaries in all these things, so it's not entirely one group. Now, most epidemiology, prevention, policy focuses on individual knowledge, attitudes, personality, behaviors, you name it. So you have all these people as individuals floating there in space. But that's got relatively little to do with reality, because people have social and behavioral ties of various kinds that form social networks, and some of which are the ties that also transmit virus. Now, the first insight is that risk networks, which is to say, for HIV, the sexual and injection links primarily, carry infections by behaviors between people. And when you map that in a community, you get a network. And when you understand that, that's why HIV can sometimes spread extremely quickly. I mean, there are cases on records of cities where prevalence of HIV among injectors has gone from 0 to over 50% in a year. I mean, that's fast. It could happen in Lexington, it could happen anywhere. The social research insight number 2 is social influence messages carry messages, norms, and other influence that can shape risk behaviors, that can shape the shape of social networks and risk networks, that can shape the extent to which people seek medical treatment and counseling, and to the extent to which people adhere to medication. So all this stuff's important for everything in the field, is what I'm basically saying. Risk networks. Okay. This is simple-minded. A lot of my stuff is based around simple-minded diagrams to give you the concept. All of it can be mathematicized and statisticalized if you want, but I'm going to focus on the concepts mainly. So within a relationship, it can carry a virus from one sex partner to another, right? Or if you focus on an egocentric level, you can say it goes to or from an individual to their various network partners. This is their first one. By the way, if I do an interview and I ask you who's in your network, that focal person may only name 2 of the people. But if we do a broader study, the third person may say, yeah, I do it with that person too. And then you've got more information. Or you can look at how a network shapes the spread of a virus through a community. And ignoring that issue and the shapes of those networks gets lots of mathematical modelers in trouble. So they may not recognize the fact. What determines whether a sexual or an injection event between 2 people results in a new HIV infection? This stuff I imagine most of you know, but it includes things like the viral load. The most important thing, though, is are they discordant? If you are uninfected and I'm uninfected, we can do any behaviors we want with each other, and no one's going to get infected. Huge amounts of money get spent reducing risk behaviors among people who are, in all probability, never going to be at risk of HIV. On the other hand, an outbreak can come upon you, and if it comes upon you, suddenly you're there, and those things can become important. I get infected for the first 2-3 weeks. It's undetectable by any lab test currently existing that conceivably could be done on me. My viral load is going sky high. I begin to develop antibody, it begins to go down. Within about a month, month and a half, the period of acute infection is over, but there's still increased transmission for the next year, according to phylogenetic studies. And we think the curve there is kind of going like that. It's going down, but for a number of reasons we can talk about later when it becomes more germane. Other things that affect things is, do I have an STI? Do you have an STI? If we're injecting together, are we sharing syringes or is the risk from sharing hookers? Totally different probabilities of transmitting the virus. Am I an antiretroviral therapist? If so, I may have very low chance of infecting you, at least as long as I'm undetectable viral load, but I can spike. Bunch of stuff like that. Doctors know much more about that than I do. But the important thing from this is given all these terribly complicated factors, HIV risk in a given event is a conditional probability. All the mathematical formulas for it say it's a conditional probability, and most of the studies, like cohort studies and other things, ignore that fact. You can look at, because they assume essentially random mixing of your partners, who they know nothing about. So what's this all mean? First of all, let me show you what some real networks look like. These are risk networks. This is some stuff that Valenthia Rempel did in Vancouver, where they went and just had some meetings with some of the sex workers in some of the massage parlors and asked them about their clients and where else they went to have, their clients went to have sex and stuff like that. The ones with the circles are where they did the interview. I'm not going to go into the details. You look at that and it's an epidemiologist's nightmare. One of those people gets infected and during the acute stage, potentially this thing can spread all over southwestern British Columbia very quickly. Hasn't happened yet. There are lots of reasons for that I'm not going to go into, but condoms are a factor. This is my first network study on a community level in Bushwick of drug injectors. And this is what we got as networks. As normal, you have one big component. You have a bunch of smaller components. You have a bunch of dyads, 2 people. And you have a bunch of people who no one else in your study were you able to link to them. They may have named one of these people, but we couldn't determine that that was the Sam they named. So they're unlinked. at least for the data purposes. We discovered some things out of that are worth knowing to show you some of the importance of networks. First of all, there's an area, technically it's called a Sedman 2 core in the studies we did. There are other measures you could use that would cause the same result. And it's basically saying the central part of the network, the more connected people, in that big component. And I'll show you exactly what I mean. Big component, the people who are connected to at least 2 other people, but not in a line going outwards. So this guy is not one of them, because you can reorganize it to look like a tree. Trees going outside from a circle. Anyone who's on a tree going outside of a circle is not part of the core. The people who are really more is. And those people have more risk behavior, more HIV, but also more communications with each other about condoms and drugs. At the time we were asking about bleach to protect things, because this is before syringe exchange stuff really set up in New York and stuff like that. And we should have asked about it. So there are centers of both health promotion and infection. Another thing we discovered is what I call my Fires wall hypothesis, that mathematical modeling of a good kind indicates as a general rule, which is, given the fact that the virus loads go down over time and the antibody goes up over time, if I have an infection that enters my city, it spreads all over to begin with. In terms of that network diagram, with that big component of 250 some people, basically in theory it could spread through those all 250 people in a year, maybe less. And if it doesn't do it that fast, what happens is people start developing antibodies. And at that point, the high viral load stuff comes up. I share with you, you have antibody, it doesn't go any further. You might conceivably infect somebody, but you have a very low viral load because of your antibody. So the infected people cause a firewall. By the way, effective antiretroviral treatment maintains a firewall. So that's good news. Before we had that, the problem was going to be people were going to die, prevalence would go down, and there was a possibility for rebound epidemics and stuff. But this is based on the typology and history of a given epidemic in a given city. It's very much a network phenomenon and can only be understood as such or used as such. Now, I just want to give you a few later network studies just to show you what they look like when you're trying to analyze the data. This is a network. I'm not going to go into all the details, but on here is stuff about injection ties, sexual ties, ties that are both sexual and injection. People, by the shape of the thing, you can tell whether a person is MSM, a woman who has sex with women, a heterosexual man, a heterosexual woman, a drug injector, a user of crack, a user of other hard drugs, or somebody who doesn't use any drugs except any harder than marijuana. And you put it all together, and all those little pluses are HIV positive. The sample was a very complicated sample, but it contains a lot of young people who are not drug users, other people. We sampled to make that happen. You can analyze that and do all sorts of statistical analysis to figure out which of the people are infected with HIV and learn stuff from that. Or you can do the same thing with herpes, which is much more widespread. Because this was done in the early 2000s, by which time syringe exchange had basically driven levels of new infections in New York among drug injectors to near zero. About 1% a year instead of 5-6% a year, or at one stage 15% a year in the late 70s. Totally different analysis. You'll get different results if you analyze this in HIV, I'll guarantee you. This is one I thought I would show you because it's an element in public health that most people don't think about, group sex events. They're remarkably more common than you would think. As I put it to research crowds, we think that's absurd because we were nerds when we were growing up. Our friends who weren't so nerdish, according to the analyses, you know, the scattered data we have during teenage years, maybe 1/3 of them go to a group sex event, and a sizable proportion of that, but not everybody, has sex at that event. And some of them do it routinely. We did some qualitative studies on that method. Very frightening. Except when you think about the fact that in spite of that, the epidemic is what the epidemic is. It hasn't, you know, in a place like this, it hasn't really, you know, mushroomed. But if you're going to think about how do you prevent the spread, you have to think about that. This is a network view of group sex events. It's also a network view, if you want to think about it, of shooting galleries or any other, what I call a quasi-anonymous risk node. A place people gather to do risky behaviors with each other. Or, if repeated fairly frequently over time, where you go every night or every couple nights to find a new sex partner, have sex with them, then you and they come back and repeat. This is what a network study will get you if you don't ask about group sex events or the equivalent, right? It's the left-hand side of that. You get several unconnected networks. But if 1 out of 3 of those people is going to group sex events, they're connected. The virus can transfer to all of them if one of them gets acutely infected very quickly. I'm not going to go into some of the fluid dynamics of those events, but they're fascinating for a person who's into that kind of thinking. We had to think it through for trying to figure out how to deal with them. So I just think I just said all that. Oh, the other thing about some sex parties, some shooting galleries, some bars where people meet to do things, is some of them have rules. Some of them have bouncers or other enforcers, or the group as a whole enforces rules. Like, we interviewed some people about a group sex party where they had very complicated safety rules, and they all enforced it. And, you know, even when they're in the midst of having sex, they see somebody breaking one of these rules, they'll call out to the person who's doing that. This is very gross and disgusting stuff to talk about, but it's what public health people have to be willing to face if you're going to do what you're going to do. We did, in that network study where I showed the diagrams with all the pretty colors, we asked people about group sex attendance in the last 12 months, and we asked them about drug use. And people in the Lower East Side and people in North Carolina have done some similar studies, not networking, but they've done asking. And what we found in our study was that the kind of drug use category you are in has something to do with the probability that you're going to go to a group sex event. So that if you're talking about drug injectors, people who inject drugs, or people who use non-injected cocaine or heroin, you've got rates, you know, around 40%. But if you're talking about people who don't use drugs or only marijuana, and this is in a young, except for the injectors, almost everybody in this is under 30. So the low drug use people are only 1 out of 4 is going to a group sex event in the last year. Now this is a high-risk neighborhood in New York. If you were to ask me what it's like in Lexington, I'd say we have no data, we have no knowledge. We're in Harlan County or whatever. But from the conversations I've been having since the couple days I've been here, yeah, not that different. So now going back to social research insight number 2, social influence networks spread information, norms, and the rest of it. Understand, these are very often the same people. My wife and I may be a sex dyad. We also share information, norms, all sorts of stuff, right? On the other hand, at some of these group sex events, you may not know the person who infects you. In a shooting gallery, you may use a needle that's just hanging there and on the, in a cup of water or something. You have no idea who used it. But it's still part of your risk network. It's a social network only in the broadest definition of social. It's not something that spreads influence. And so we make the distinction between risk and social influence networks because we think it's important. And particularly when you're studying drug injectors, it's always important to understand they have lots of social ties who are not themselves drug injectors and whom they don't have sex with, but who influence their behavior in lots of ways, like giving them money to buy drugs with, or some good parents do that, or maybe bad parents, or giving them syringes, diabetic neighbors who routinely give them syringes so they won't get infected and stuff like that. And people will simply say, why don't you go into drug treatment? And, sometimes help them to do it. That's part of their social influence network. That's the identical thing about the spread of it. This time the spread of influence instead of viruses. Everything I said before is the same. Another thing that's a little bit of a digression, but people often miss it. The people who are at risk for HIV have organized themselves to protect themselves. They've done it in small groups. They've done it in national organizations like the International Network of People Who Use Drugs, the equivalent, 2 or 3 different equivalent sex workers groups, gay men you probably know all about. They have an enormous web of organizations. I could put an organization chart that would be more complicated than those social network diagrams for some of their stuff. They're really well organized. And these things have sometimes been set up even before the virus entered the circles in any large amounts, and we're protective. They also have a lot of influence on international and some nations, the national policies on HIV, drug use, sex, you name it. I just want to talk a minute more about roles and stuff like that. I think I did it, actually. There are managers, there are role holders, bouncers, condom enforcers. Intervention. Look, one of the things we discovered and documented, we knew it all along, in the same study with the pretty network diagram, was that people engage, drug injectors, non-drug injectors, all people in the community, engage in health education all the time with their relatives, friends, neighbors, co-injectors, whatever. They say things like, use condoms. Or perhaps don't use condoms. That's all a myth. But people are constantly giving health communications. Most of what we pick up is pretty accurate. Sometimes they've been ahead of what public health practice has been. Some of the negotiated safety stuff in Australia has been very sophisticated and community developed, for example. We call that intervention. And intervention is, so Alter does intervention to some of her friends, right? One of her friends is ego. Part of my environment as ego is Alter's health education to me, right? Now, another way of thinking of that is, actually, let me go, I think this is better to do it on. This person's intervention is ego's norms. Not norms in the sense of values and beliefs, but norms in the sense of the social influence I am constantly under to behave in certain ways and not others, which is the basic sociological definition of norms. And if I have a behavior, it helps me to maintain that behavior. If I don't have that behavior, it may convince me to have that behavior. That's called peer influence. If it's a peer doing the stuff, if it's mommy doing, if it's my mommy, whatever. So we have interventions and norms affecting behavior, none of which is terribly new or surprising to anybody. However, you've got a community-based organization, a health department, a PSA, you name it. they often do this stuff having no idea about what interventions and norms going on in a community are. I know lots of things that Dick and I had taken part in back in the early days of the epidemic. We were going out and teaching people things, and the drug injectors, at least in New York, all knew that already. We were being maybe a part of a kind of a parallel to some of the intervention, but often they were more sophisticated than the messages we were at least officially supposed to be giving out. In fact, our outreach workers were very savvy people. They figured out what was going, some of them figured out what was going on very quickly and, developed very helpful messages. But that's because no one on top was keeping them too strictly to the message. You can have situations where people are saying things. Let me think. I used to have examples of this at my fingertips, and I'm blocking. But when the health department or the outreach group is saying do X, and in fact, what the community is already doing is much more sophisticated. Particularly when they say you have to keep messages simple, which is a common health education mantra. Well, I don't know about other communities, but drug injectors are and other drug users are very sophisticated about some of the aspects of drug use, and at least in places where they've had HIV epidemics, very sophisticated about HIV. And some of the simple-minded stuff we sometimes teach to keep it simple is in fact they're just going to look at what you're saying and say, okay, these guys are just preaching their preaching, but we know better. And they're right. We could even be hurting people sometimes if we're not very careful. One of the uses of qualitative research, and I'm told you don't have qualitative research training in the health department, the public health school, and if that's true, I will recommend to you that you change that reality. Because in order to do interventions, you have to know how to find out what's really going on in the community. It's very easy to hold a few focus groups and think you know what's going on. And as somebody who's very experienced in both quantitative and qualitative research, I can tell you, the chances are 95% that you missed what's important. You need a more dense qualitative research to get some of what you need to know. So what are some of the implications of the talk so far? How am I in time? Oh, I'm taking too long. Okay, a lot of the behaviorist epidemiology kinds of approaches don't capture the network stuff at all. And that's misleading. A lot of the big cohort studies of HIV, anytime you do a cohort study of HIV and only have the behavioral stuff, what's guaranteed is that any network variable that is correlated highly with any of those behavioral variables is a confounder you have not measured and may in fact be the causal thing. There's a lot of people who go around and say things like, the head of the Dutch epidemiology on HIV in something like 1997, I was reminiscing with him about some of the old days and talking about how, back at a certain point he had argued against including information about whether women injectors were having sex with women. And, how mistaken that had been, essentially. I phrased it in very friendly terms. And he said, WSW, how can it be that they would be at more risk? And this in spite of the fact that there's been a lot of articles published showing, yes, they're 5 times more likely to seroconvert than other injectors. He thinks of it as if the behavior is the risk. No. WSWs inject more and have sex more with MSM. They also have very tight injecting connections with each other. So if it gets in there, it spreads rapidly. So, if you understand networks, you understand that, and social science, you understand that kind of thing. If you don't, and you do a cohort study, it can be very dangerous in what you're finding. And just one of the methodological weaknesses of one of our favorite tools. And it's a hard one to avoid. The folks like April and Jennifer are avoiding it, but they're spending a lot of money doing that. And, that it's a problem. Yeah, I've said that enough. I'm now going to move to my current intervention, the Transmission Reduction Intervention Project. A little bit of scientific background. At least a quarter of London men who have sex with men transmissions from phylogenetic analysis take place in the first 6 months after becoming infected. They have some similar data from Montreal. Some other people have been using math models have challenged this, but the math models are not good ones in the network stuff, for example, so I don't take them too seriously. But, you know, there's some questions. And it's partly the question of higher viral load, but it's partly also a question of you're most likely to get infected when you're in a stage of relatively high behavior in relatively highly risky networks. And that tends to be true of some of your friends, and there's a statistical probability that increases the probability that I, as a newly infected person, may be infecting somebody else 4, 5, 6 months down the road, even if my viral load were to go down to fairly average levels with antibody and suppressants. That's the kind of, set point kind of a viral load. And another thing is current methods of treatment as prevention and HIV testing have real trouble reaching people within the first 6 months or so after they've been infected. Not that they select against it, it's just that people don't come that often. And if they did, that overwhelmed the capacity of the system. So we said, we're going to figure out a way to get people soon after they got infected. We're going to use social network techniques to do that. And by the way, there have been very few really successful efforts to use social network to prevent the transmission of HIV. It's a very hard thing to do. How do you find people who are recently infected to be the seeds of this intervention? There's a nice new lab test, which you can use everywhere but the United States, because it's not FDA approved yet, called limiting avidity testing, which will tell you, developed by CDC, and it'll tell you whether or not, they're working on getting it approved, within the first 6 months. We use it in Chicago, but we can't tell people anything or base our recruitment based on anything from it, because that's using a test diagnostically, which is not even in a research project, you can't do that. You also often, if people are testing fairly frequently, can find some seeds by documented seroconversion. They tested negative less than 6 months ago. They test positive today. Zingo, they're a seed. Or it's not technically a test for recency, but a person has a high viral load, which we define as more than 100,000 copies. We treat them as if they're recently infected. A lot of them are. Some of them will be somewhere else in the process, but they're very infectious. We want to reduce transmission even from the people we do not locate, never talk to, as well. And we want to make treatment, antiretroviral treatment, available as fast as we can to those we do locate, particularly those who are recently infected, so we can cut off the early transmissions as fast as we can. And so far, from we're early in the 4th year of a 5-year study, and having some trouble. One problem with network studies is the data, and keeping track of all that data and analyzing. When you're doing it in 3 sites with 3 languages, it's even harder. So we've been having some database issues, which have slowed up some of our analyses. But from what we can tell, we're recruiting a lot of recents. And we're particularly recruiting recent people in the networks of recents. And I'll explain some of that quickly now. Our intervention is we find the seeds, we ask them to name their risk contacts, which doesn't just mean they're direct sex partners, but people who may be present when sex is going on, that they are engaged in, or drug use that they're doing, using drug use. Because we figure people have social ties, and the people who do something this week may not be doing it together next week, and vice versa. So We then go out and recruit the network contacts. We also ask them about the quarries, the venues where they do things. And we figure we'll recruit from those venues. We all then go into a network community alert system. And this was the risky part of the project, where we were afraid and did some careful piloting to make sure we weren't killing people. We basically passed into those networks by way of the members of the networks, included the recently infected person, leaflets saying, somebody in this immediate social network, micro social environment, is highly infectious. It's likely, in fact, it's not just one, it's probably several. For the next 6 months, be super cautious. And our fear, of course, was that that would get the people passing them out, beaten up, killed, whatever. Bottom line argument, answer on that is it has not happened. This is the most aggressive social network intervention I've ever heard of, just about, the riskiest. Nothing happened. Anyone who has trouble with any IRB on these issues, or just nothing happened. And we've processed thousands of, well, maybe 2,000 people through the intervention by this time. And then we, of course, try to link people to care, particularly the people who are recently infected. This is the logic. It's a very simple logic. Some person up here infected somebody. They infected some more people. The infection chains travel all over the place. My direct networks are one group. If I'm a recent, I may have infected them or been infected by them. But there may be a parallel transmission chain from somebody else in my social world who is not directly linked to me, which is why we take these. Beyond that, it's something about contact tracing. And I was talking to some of the health department people and saying, this is a problem with the way contact tracing is done. They stop at negative. I'm contact tracing your contacts, I find a negative. And we don't ask them for their contacts, and we don't follow those contacts. From this logic, that's a mistake from what we're seeing in the field. I don't have the stats with me, but I can tell you they're there. Particularly in Athens, where we've been able to do the best analysis. The second level contacts are important. And I suggest to health departments that they try it out. Go one step beyond the negative and see what your yield is in terms of infected people. Depending on the shape of your networks, it may or may not be something that's important. But maybe it's terrifically good public health intervention. Okay, this is the whole point of this slide is using these community alerts. If I'm recently infected, I don't know it, I don't get tested, I don't do anything. I'm totally missed by the intervention. But if my networks are caught by the intervention and for 6 months they basically don't take any risks, I can't infect. We work with community-based organizations to get people into treatment, even against the guidelines of the national things about 350 CD4 cells. That's routinely simply ignored in Greece and sometimes gotten around in Ukraine, though that's harder. And in Chicago, that's not a problem because the rule doesn't exist. We have good case management based in community outreach projects, not based in the medical system, to help people get stuff. And we're measuring how many people we recruit who are recently infected. We're measuring stigma and other bad outcomes which simply aren't happening on any level greater than with any HIV testing. We're going to be doing some phylogenetic assessment several years from now on to get some ideas about transmission from participants. So TRIP seems to fill, although we don't have proof of it yet, a major hole in treatment and prevention by quickly recruiting people who have acute or recent infection and getting them into care. By the way, we test for acute infection by using pooled samples techniques. But alone, it's not enough. We actually busted the Athens outbreak that started in 2011. Not so much due to TRIP, but due to our group, which is chiefly Athenians, but we were involved too, getting them 500,000 extra syringes from the federal government, or the national government of Greece. They improved their drug treatment programs, and they set up a huge, basically education, case detection, and intervention project using RDS methods that processed a bunch of people very quickly. And we drove infection rates down from 13% to about 1% in about a year or 2 years doing that. In New York, by the way, Syringe Exchange drove it down to less than 1% now. And when you look at the diet, we published in Lancet an article in '96 showing basically went zoom. So that's the end of my talk. I talked longer than I had hoped to. I will take at this point discussion, questions, disagreements, preferably polite ones, but if you want to call me names, I'm not going to worry too much. Anything about underlying concepts, anything about syringe exchange, harm reduction, anything.
So Nancy asked me to MC, so that...
Right, even call by name if you know it, because there's people here probably whose names I know, but won't remember.
Sure, Dr. Friedman.
So, Doug Thurman, I'm actually with CDC, but assigned to the Kentucky Department of Public Health, so we're dealing with this issue with of course, the Austin, Indiana situation.
Yeah, by the way, the people in Indiana, I really admire the hell out of.
Yeah, they did a lot of fast work. Yeah. So my question is, so I missed the beginning of your talk because I stupidly didn't look at my email and I went to the wrong place. So, so I don't know if you discussed other things, but it seemed like most of the places you talked about are dense urban areas, and so I wanted you to comment on how you would see, or maybe Dr. Young can comment also on the differences between urban populations and drug-user populations. We're primarily, we have urban areas that we have a lot of transmission in, but we've got huge issues with some of our rural areas.
I think it's, they have things to say that are supplemental to what I'm going to say, but some of the basics are real, both places. If you go to some of the hollows in Harlan County, say, you've got a lot of people, not huge numbers, but you've got maybe 20 people, 30 people who inject together and have, I don't understand their sexual networks and mixing patterns, but they're there. And if somebody there gets infected and has high viral load, it's going to spread real fast. So when you're talking prevention with them, a program like TRIP, actually in areas dense as a given hollow, it may be too slow. May keep the spread from one place, one small group to another. Maybe I'll slow that down, which could be really strategic. The best thing to do is to have lots of syringes and lots of condoms everywhere. I mean, I think we understand that now. People who didn't understand it a year ago understand it now. We have to avoid any red tape we can in having that happen. There are people here who are health students. Everywhere I know, in urban areas, but it's true to some extent in rural areas. Health students volunteer as syringe exchange people or outreach people, and that's how they learn about realities of what communities are like, not just drug using, but the whole neighborhood. They learn about them in ways that are helpful for years. It's not, public health has a long tradition of going into rural areas to do interventions. And what people learn is, they're totally different in terms of some of their social norms. They're totally, some of them at least, are totally protective and distrustful of outsiders. So the answer is you set up connections, and so they're getting drugs from somewhere. Well, they can get syringes from places too, and that's probably the single most important intervention and the cheapest. Don't worry about issues like if I give Sam a box of syringes, he may take it and sell them to the other drug users. He's the cheapest public health assistant you'll ever hire. And it's simply, common sense. Don't worry about that. If there's a law against it and you're a policeman, don't notice it. Because I will tell you that around the world, police are often at the front lines of prevention just by not noticing what's going on. And talk to the cops. Get them on your side. You know, they're worried about finger pricks when they go pat somebody down as a drug user. They should worry about it. They're going to get a hep C maybe. Well, we and they are allies. We don't want them to get infected either. And the way not to get infected is basically say to the person, look, if you have a syringe that's been used, let's get rid of it now in a safe way. I'm not going to hold it against you. I'm not going to use it as evidence. And, you know, we'll do whatever we're going to do irregardless of that fact. I don't know if that really is fully responsive, but it's...
Yeah, because I was thinking of some of the actual attitudes about disease, and I don't know if, April, you can talk about that. I've sensed from some of the stuff in Austin, Indiana, and some of the stuff that they've done down in Hazard, you know, that there's less of a concern if someone is infected, that people are maybe not as worried about infecting other people or getting infected as maybe it sounds like some of the folks were in your...
Depends where. In Athens, they weren't that worried. In New York, they're worried because we went through a period in the 80s and 90s, you know, period of great dying. I mean, everyone knew lots of people, particularly in the affected neighborhoods, who died. And they died slow, they died agonizing, you know, it was really miserable. Everyone knows that. Now, as we're getting a few more years down the road, that's going away in terms of what's conscious in people's heads. But the old heads in the drug injection scene, they remember it, and they tell the young ones. And to some extent, it's still a social fact for them. I think experience is what teaches you, but that people know anyway. And, you know, no one really wants to have to be taking pills for the rest of their lives, and stuff like that. But did you want to speak to that at all?
I think, you know, we do have a sense of invulnerability in Eastern Kentucky, not to Hep C, but to HIV. And I think that our obsession with setting up syringe exchange programs in Louisville, Cincinnati, and Lexington sends a message to those folks that they are invulnerable. So perhaps it is our actions that is leading to that invulnerability or that sense of invulnerability. And so I would say that I think if we put our actions behind our words and put syringe exchange programs in Eastern Kentucky, it would show them, we think you're vulnerable. And it would send a clear message.
Yeah, the other thing that's important is this isn't sex. People don't like wearing condoms. People like having new syringes with clean, good needles because they're less likely to harm your skin or screw up your veins. And, you know, those are real issues to drug users. And so if this, you know, that's why it's so easy to prevent HIV spread among drug users. Is because you're doing something, you're just helping them do something they just as soon do anyway.
Dr. Friedman, my name's Janet Gilligan. I'm the program coordinator for the AIDS Education Training Center here in Kentucky, based in UK. My question is, I'm working with a public health educator out of northern Kentucky that's very concerned with the lack of testing among the physicians in that area. And he is very interested in moving the bar just a little bit toward providers doing more testing. There's a lot of resistance with cost. They're having patients do an extra questionnaire just to get tested. Physicians not feeling like it's really a problem, although they're number one in hepatitis C and they know they have a drug problem in the area. Do you have any thoughts on providers in this epidemic at this point?
Can you all hear back in the room or do it? Okay.
I know remarkably little about providers in northern Kentucky. The basic rule is lots of people can counsel and test. It takes relatively little training. It takes some. By the way, lots of people can do phlebotomy with relatively little training too. And there are rapid tests. And the economics of it I can't speak to because that's really very local. But it's often cheaper than you think if you're willing to, and you can get volunteers. I know, for example, that, and this is in the New York context, so it's not exactly northern Kentucky, but there's a medical school. So this guy doing a community program in one of the outer boroughs of New York, and says, can you guys send some residents over a couple times a week to do some community service and training? And the hospital says, great idea. So sometimes you can get free residents. You can get some very good training for nothing. So you have to get creative in everything about public health. You have to get creative. I'm not saying people aren't, but I am saying that people often don't realize that they should and that it can be effective. And other people don't realize that it's often better not to know there's certain kinds of things that may not be authorized. They may not be unauthorized, but they may not be authorized. Well, you just don't notice it. Or say it's a pilot.
John, do you have a question?
Sure. Hi, Dr. Friedman. John
Hi.
Moses, Fayette County Health Department. I think you made a really good point earlier when you were talking about younger people and public health students, because ultimately it's going to fall on that generation to really get things moving along, because a lot of the resistance that we saw here in Lexington in implementing our needle exchange came from older individuals and people who were resistant to change. And so it's going to take public health students of today with the desire to make a difference to really push those boundaries and to push and drive what's going on.
Also the people in the community. A lot of people in neighborhoods are perfectly happy to help. They don't want to see the epidemic spreading among their children. Now, everybody has a very legitimate concern about, I don't really want my kid to overdose. Or get arrested for it, or whatever. And those are real concerns, and sometimes people leap from that to saying you shouldn't keep them alive uninfected, which is simply a logical discontinuity. No evidence anywhere, trust me, we've looked, that setting up syringe exchanges leads to more injections, more drug use, any of that. It just doesn't seem to happen. I mean, people can create scenarios where it will happen, but if it happens, it's at such a small scale, no one can detect it. And I remember one of my earlier studies where we were asking people where, there was a syringe exchange in the neighborhood, and we were doing a population representative sample of 18 to 21-year-olds in that neighborhood. So we asked them about syringe exchange and a few questions, including, do you know if there's one in your neighborhood? Nah, they didn't know. So that a lot of those kinds of fears simply are groundless. Now, this is where the difference between New York and a small hollow somewhere, you have a real syringe exchange office or something in a hollow, people are going to know about it. But if you have it, going on more through satellite exchanging, we call it, set it up in one of the cities, towns, so that people can go to some place where there's several different activities happening, one of which is you can get syringes. That way it's at least semi-anonymous why people go into the building. And they take that many syringes, that'll last them for a week or so for the whole group there, even in a wild time. And then one of them comes back and gets more. Maybe they return it. It's best, obviously, if you can have them have some sharps containers to bring it back with and stuff. But it's young people, young people, not just students. And
Young people in general are more open to...
But some old people.
Yeah.
I mean, there's a lot of people in the community who want to help their community. There can be church involvement if you have the right ministers or, other people in the church, This is public health, guys, Some people may have, what they call moral objections to it, but, public health goes beyond that for
And that's
a
what
lot
I was
of people.
getting at, is
Yeah.
that younger people are more okay with men who have sex with men and understanding injecting drug use and understanding different cultures
Well,
that maybe
there's a lot of
50
people.
years ago were.
Remember, there's a lot of people from my generation, and people 10 years younger than me still around. And a lot of us, in one way, shape, or form, went through various movements, actually. Some of them were civil rights movements, some of them were miners for democracy, so, all that stuff. Some of those people are still around, and in New York, some of those people are very involved in stuff, even though they're older. Here, you only learn by trying. So I'm saying, preconceptions should be tested. But I'm pretty sure the students, all these guys who are leaving, should think about volunteering in various ways. Because I'll tell you, a lot of people I know who have done that have found really very rewarding and high-paying jobs through that process.
So before too many leave, let's give Dr. Friedman a hand, and if whoever wants to stick around for a conversation, then feel free to stick around. A lot of folks have class.
Yeah. And anyone who has questions about some of the network logic and stuff, there hasn't been a single question almost about that yet. Maybe you already know it because of April antennas. Yeah.
Dr. Friedman, I was wondering, in your two-mode network of people and events.
Wait 1 second.
So,
People who are leaving, please keep quiet so he can talk.
in your two-mode network of people going to event venues, you said that you don't feel the events really influence the norms of the individuals, or that the events didn't have norms that they were transmitting to the individuals. And I was wondering if you think individuals select events based on norms they already have, and if those norms, if going to an event influences the individuals, to what degree that influences the behavior.
One of the perennial questions
Yeah.
of which is reproduced in all the studies of peer influence. And the answer is, by extension from what I know about those studies, is yes and no. Don't frame it as a dichotomy when it's both. Sure, I go to events that I want to go to. But I bring a friend because they want to come with me to that event. And they may be influenced by what happens at that event. It's all the complicated messiness of real social reality rather than what happens when we try to do it with regression equations and fancy modeling. I think that in either case, for the people who are coming, some of those people aren't going to the events, but they're being network connected to other people, which is the other thing. And because people always look at those kinds of questions in terms only of the individual and what happens to the individual's norms, well, I didn't go to the event because it wasn't my kind of event, but in the meanwhile, I didn't get infected because the person who did go to that event obeyed the rules there and didn't get infected, whereas they otherwise would have. So you've got to look at it in terms of what's the issue at hand, which isn't normative change or even behavior change, it's whether the virus spreads in this case.
Are any other questions?
Yeah.
I was wondering, thanks so much for your talk. I know there's been some that's been written on using networks and thinking about contagion, but for very different illnesses that are non-infectious. And one which is controversial as to whether it's an illness or not is obesity. And you talked about different types of risks that pass through networks and ways in which networks are influential. And so I was wondering if you could talk a little bit about your your perspective on applying this type of network analysis for very different types of illnesses.
Yeah, I mean, I really have focused on infections. And it doesn't have to be sex and drugs. It can, you know, people do influenza or TB or whatever kind of stuff, including interventions based on this. There's a huge literature on networks innovation. I'm not on top of it, so I can't speak to that literature. But if you want to understand the flow of information and influence in relation to that, there's going to be a temptation in network studies to be too simplistic and to ignore some of the other social things going on. And people get too gung-ho about networks and don't go looking at context and all the rest. But partly because in a research study you're limited in what you can do. And, you know, I'm not knocking them. But try to build in some of this other stuff, kind of the way we're doing it when we talk about group sex events, or is some of the things about is there a program in the area or stuff like that. You have to take that stuff into account because it's also, and it's not necessarily, I mean, this gets to some really tricky stuff. It's not necessarily independent factors that statistically when you analyze it, the equations work out in a given way. Although you can get some approximations with that. Sometimes things are just more interactive and intersecting than that. And when you start getting into some of these social realities and normative concepts and mental fields kinds of concepts. So, I basically know that I'm much too ignorant of that whole issue to be able to say anything very useful beyond look a little more broadly than people usually do.
Okay, we'll take, Mari had a quick question.
Hello, my name is Mari. I'm from the Kentucky Department of Public Health HIV Prevention Program, and we're about to implement the social network strategy for the CDC has, and I wondered if you were familiar with that.
Is that the one based on Carl Atkins' work, or is it a different one?
I'm not sure. It involves
Is SHIELD?
Wow, you don't know if it's SHIELD.
It involves what?
It involves like drawing a social network diagram and recruiting people to come in to get testing. I don't know if it was based maybe off your work or.
It might have been probably at second or third generation. I mean, it may be based on some of Carl's work, and when he was developing that, we were in close communication. It may be different. I mean, there's a lot of social networking stuff. For recruitment, social network stuff works pretty effectively. RDS techniques can work, but they're less specific. So that you're going to get a lot of people who aren't that connected. I would argue that based on our experience with the TRIP project, that you may want to build in a recency component for extra special attention, and definitely going to the second step and asking not just about the direct contacts, but the social in that context. Because I think that will be more effective. And if you need to figure out how to evaluate that or something, we can help you.
I'll talk to April.
Okay, I think we have time for, we have a lot of questions all of a sudden. Carrie?
I just have one question about treatment as prevention in terms of hepatitis C, because we're having a problem with that in Kentucky. And wanted to see if you could speak to that a little bit, and also the role that new hepatitis C medications play in that treatment as prevention approach.
They're fundamental to it. I mean, because it's fast,
Yeah.
and it's something people can easily get through. All the evidence that I know of is that active drug users can get through those programs successfully. Not all of them, but, a lot of them. And probably at rates roughly equal to that of people who aren't active drug injectors. And there's a lot we don't know about it. What we know about it is based on analogies with HIV and mathematical modeling where we don't really know for sure that we have all the factors in the model, or even are using the right kind of modeling. So that, you know, a lot of the modeling's been compartmental modeling, which, for reasons I presented here, can't cope with some of the network stuff. But, you know, I'm optimistic about it. I think that it's almost public health malpractice at this stage not to be aggressively moving on Hep C treatment.
Blake.
Hi, Blake Fahar, AIDS Volunteers. I was wondering if you could speak to PrEP, where that fits in all of this. I know that some of the efficacy studies were done among people who inject drugs, but have there been studies done on maybe as far as acceptability among people who inject drugs, like within these networks?
It's tricky. I can tell you as a fact that people in some of the drug user organizations, like the International Network of People Who Use Drugs, are making the argument that they're afraid of it. And they're afraid of it for several reasons. They wouldn't use the word afraid. I'm afraid of it. I'll use the word. First of all, in a lot of the world, the money doesn't exist for everyone to get the treatment. And they're saying you're using a lot of antiretrovirals for people who aren't infected when other people are dying. And that tends particularly to be true for drug users. Secondly, there's the whole question of evidence of whether or not it works. And thirdly, they're afraid, and I think rightfully so, that people are going to take treatment as prevention and PrEP as policymakers and say we don't need syringe exchange, and which is the cheapest and most effective prevention for drug users. So now on the individual drug user level, in a lot of places people have never heard of PrEP. Maybe on a case-by-case basis where they know about it, they have some interest. But on the other hand, if they're not too sexually at risk, they figure a clean syringe is better than PrEP, higher probability of success. Some lingering questions there about transmission through shared other mechanisms like cookers, but probably still a higher success rate in preventing transmission through clean syringes and a little bit of care about that other stuff than PrEP.
Thank you.
Okay, last question, Dr. Fleming.
Hi, I'm Steve Fleming. I'm a colleague of April's in epidemiology. So in a typical case-finding approach, I mean, in STD, you would have a case, and then you'd ask them who they had sex with, and you go to their cases and so forth. It seems like the network approach of yours basically has done the case-finding a priority before the disease. So if you get one of them that has HIV, for example, you already know who the potential cases are. But since we haven't mapped out most networks everywhere, I guess my question is, I'm not sure you can answer this, but are there general principles among all networks that would facilitate or actually speed up or make the whole case-finding process?
We are working on that. First one is the thing I've said. It's not only your direct contacts. Understand the context, because when you use the term we haven't mapped all the networks, in principle that's impossible. Because I may be having sex with you today, but that doesn't mean I'll be having sex with you a year from now. And they change, and that's one of the reasons viruses and bacteria spread so fast, potentially. Now, we have a set of questions which asks about other people who are present or things like that. It may be a little too expansive. We're currently setting up a pilot study in Odessa where we're learning from CDC in Indiana. And they asked the question to drive their network stuff, who else do you think should get tested? We're interested in getting recently infected people, so our approach is going to be teach them some of what I just put on the screen about how viruses spread, when they're spreading quickly. And I put it upstream, downstream, and side stream. And then say, think about that. Tell us who should be tested for recent infection so that they don't infect other people, and so that, et cetera. And we're going to give them coupons. And what we think we're going to do is we're going to give them coupons for everyone they name. They bring them in. These are the green coupons. And we'll give you some pink coupons, 5 pink coupons, for the people you forgot or did not want to tell us about. Give it to those people. We figure some of them are just going to be, we pay people to when the coupons come in and stuff, but so some of it's going to be bogus, but it's cheap case finding. Given that we have reason to think that their networks are particularly rich in recently infected people. The other big thing, case finding stops at the negative, and it shouldn't. Certainly not for HIV, probably not for STDs of any kind, or bloodborne, because people tend to do things in groups. And over relatively brief times, you can't count on things not changing in terms of who's doing what with whom. So, depending always on the economics of your project and everything else. But our hypothesis, which we're kind of trying to test, and our data so far seems supportive of it, is you don't stop at zero, at the negative. You go one step beyond, and then make a judgment call. Because you're always in a certain situation of real uncertainty. And it's not that it's because you don't know things, it's because the networks change. And so you're trying to figure out what's the best guess to get the most people as quickly as you can to prevent the spread of stuff.
All right, well, we'll wrap up so people can have conversations, but we'll need to get out of here in the next 5 minutes. I think they have a group coming in. Thanks again for coming, and we'll give them Dr. Friedman another hand.
And you guys got a good question. Very good question.